Hello, welcome to video 3 of my antibiotic series. And in this video, we're going to continue the scenario that we picked up and started with in the previous video with a child with a suspected community-associated pneumonia. So previously, we've had a young child who's come in with a suspected upper respiratory tract infection. We started them on a course of amoxicillin, and the main reason for amoxicillin was that it's going to kill any causative strep that might be causing an infection. So what we're saying now for this current situation is the child's situation has deteriorated. So they're now more unwell, they're vomiting, their fever is now 39 and a few other observations. So blood pressure, respiratory, maybe a little bit lower than you'd expect. So this is a little bit of a make-believe situation because in reality, we've not given any details about how long the amoxicillin was given for and so on. But what we do know, the situation's got worse. You might be thinking in the back of your mind, maybe the amoxicillin hasn't worked. We haven't covered the causative agent, so we need to go up the ladder and prescribe a more broader spectrum antibiotic to kill a wider range of potential causative agents. The other thing to say is that because the child is now vomiting, we're no longer going to give oral antibiotics for obvious reasons. We could potentially switch over to ampicillin, give that intravenously. Ampicillin is the chemical cousin of amoxicillin, so it's very closely relating, very similar spectrum of activity. So that possibly would be another option. But for now, we're going to be thinking this child's getting worse. Maybe in the back of your mind, you're thinking sepsis. So in that situation, what we're going to do is we're going to move up to a cephalosporin, and in particular, in this video, we're going to look and think carefully at ceftriaxone and ceftaxime. These are two antibiotics we're going to consider together. They're both third-generation cephalosporins, and we consider them together because they have the same spectrum of activity. The differences between them are pharmacokinetic, which impacts on dosing. Let's go back to our chart and let's think about what does ceftriaxone work against. We'll focus more on this because you'll see this arguably at the moment it's used more frequently. What we gain with ceftriaxone is coverage against methicillin-sensitive Staph aureus. So we do gain a little bit of coverage in that sense. So Staph aureus can be a cause of upper respiratory tract infections, but it's less common than strep. We still gain that strep coverage, so that's good. That's kind of giving us that continuum with the amoxicillin. We lose the enterococcus coverage. Now, arguably, we could say that's a good thing because enterococcus here is very, very unlikely to be anything involved. And so what we're doing is we're actually, by moving the antibiotic away, we're going to be preserving that and other collateral organisms which might be affected. So that's good. Ceftriaxone is a third generation. Third-generation cephalosporins are defined by having much better gram-negative coverage than generation 1 and 2 cephalosporins. So unsurprisingly, we're going to see that it works much better here on the right-hand side. So we're going to start now killing enteric gram-negative rods. Arguably, that's bad news because common sense would indicate that those enteric rods are unlikely to be involved here if we've got a respiratory tract infection. So we're potentially now going to start killing other things that we don't necessarily need. It does, however, work against the respiratory gram-negatives, and that's good news. So Haemophilus, Moraxella, and Neisseria. And what's significant here is that the antibiotic, these cephalosporins, get into the central nervous system. So other antibiotics can as well. Penicillin is a good example of an antibiotic that can cross, but it requires quite a lot of inflammation in order to make the blood-brain barrier leaky for the antibiotic to cross. Cephalosporins are a bit more lipophilic, which means they can cross a bit earlier, so you don't have to wait until the latter stages of the disease in order for the antibiotic to get in. So it works here. Specifically, Neisseria meningitidis. It's unlikely that the child has meningitis. We don't have any of those other symptoms, but it's useful just to note. It doesn't kill Pseudomonas. Pseudomonas still is not covered here. There are cephalosporins that do work against Pseudomonas. We'll cover those later, but it's not covered. But there's arguably at this stage nothing really to say that we need to be thinking about Pseudomonas just at this stage. Cephalosporins are cell wall active, and so as before, we have no coverage against any of the atypicals. So Mycoplasma, Chlamydia, Legionella, there's no coverage. Again, arguably, we could say there's no real need. As before, we get some oral anaerobic coverage and no GI anaerobic coverage. Again, that's not necessarily a bad thing, but it's just something that we need to be thinking about. Here, it's about increased gram-negative coverage. Let's go back to our chart. So this is the chart which we built on before, and it kind of just reiterates many of the things that we've said. So amoxicillin, again, you can see quite focused coverage, but here, ceftriaxone, we've got MSSA covered, and look at all the gram-negatives that we've now included. And in particular, you know, we've got one or two other organisms, which sometimes arguably, so E. coli, really unlikely. There's nothing really to say there's an E. coli infection. You need to be aspirating serious amounts in order to get an E. coli respiratory tract infection. Klebsiella pneumoniae, again, rarer, but we could be thinking about. But it's these guys. It's the Coccobacilli, Haemophilus, and Moraxella, which are useful now to be thinking about. Let's go through. This is a screen grab from the RX guidelines 2021, beginning of 2021, and you'll see that for a child, if thinking sepsis, ceftaxime, or ceftriaxone IV, and you'll note that we can add additional amoxicillin if we want to cover listeria, but we could be thinking sepsis, and sepsis is a useful one. Or when we're thinking about deteriorating child, that could be in the back of your mind. Why would you pick one or the other? It comes down to dosing. So their spectrum of activities the same, but you'll see the paper that I've just found some evidence from here. Ceftriaxone is administered once daily, and ceftaxime needs twice daily administration. So they're the differences. Dosage and review are conversations you probably have with a medical microbiologist and or an antimicrobial stewardship or pharmacist. Okay, so that's the end of video 3. In the next video, we'll consider this particular child situation and a further change in their status. Thanks for watching.